Hi, my name is Dr. Matthew Reddick. I'm a genitourinary medical oncologist at UCLA School of Medicine, and I'll be moderating today's virtual tumor board. I'd like to introduce you to our panelists. First, we have our medical oncologist, Dr. Susan Slovin. Dr. Slovin, please tell us about yourself.
Thank you, Dr. Reddick. I work at Memorial Sloan Kettering Cancer Center in New York. I'm also a genitourinary medical oncologist whose focus has been on prostate cancer with a longstanding interest in prostate cancer immunotherapy and biologics. Thank you for having me.
Hello, Dr. Pritesh Patel, Associate Professor of Radiation Oncology at Emory University, focusing on GU malignancies.
My name is Jason Abel. I'm a surgeon, the chief of urologic oncology at the University of Wisconsin.
I'm Dr. Tyler Fromm. I'm a radiologist at Washington University School of Medicine in St. Louis. I'm an assistant professor with appointments in both abdominal imaging and nuclear medicine. So I do a lot of oncologic imaging below the diaphragm.
So this is a case of a 73-year-old Caucasian male with very high-risk prostate cancer, T3B, N0, Gleason 4+5 with a PSA of 7.18, who completed external beam radiation therapy and brachytherapy with a brachytherapy boost and 1 year of total androgen deprivation therapy, now presenting with a cough for a year, but did not get a workup due to COVID-19. Primary care provider eventually ordered a CT scan, which showed a hilar mass for which a biopsy revealed metastatic prostate cancer. And our ultimate question is, what are the next steps in the treatment of this patient? So here's the detailed case presentation. The patient presented with a cough for a year and worsening dyspnea. He has an ECOG performance status of 1, so minimally or mildly symptomatic. The patient has, of course, his medical history of prostate cancer. Social history, has no tobacco or drug use, and drinks 3 to 4 beers per day. The family history is quite notable. The history of colon cancer in the father and a brother with prostate cancer. In September of 2018, he was started on he has diagnosed with high-risk adenocarcinoma of the prostate, as we said, T3B indicating seminal vesicle involvement, Gleason score 4+5 and a PSA of 7.18, and the patient is started on combined androgen deprivation therapy, initially with bicalutamide, and then in April of 2019, triptorelin, an LHRH agonist, is added. By July of 2019, the patient has completed external beam radiation to the prostate and pelvic lymph nodes, and has also completed brachytherapy boost by August of 2019. By October of 2019, the patient had completed 6 months of triptorelin, but stopped due to forgetfulness, impairment of mental cognition. And by December of 2020, the PSA starts to rise from 0.19 to 1.98. I'm going to pause here and ask our radiation oncologist, Dr. Patel, to comment on this rise in PSA, and does that signify a true biochemical recurrence or not?
Thank you, Dr. Reddick. So for anyone who's been on androgen deprivation therapy, certainly I think we'd want to see the total testosterone as well with the PSA values. So if there's a testosterone recovery after the cessation of androgen deprivation, certainly PSA will rise concomitantly. So certainly one aspect there. There can be a PSA up and down PSA. So we typically look for 3 consecutive PSA rises in the setting of a stable testosterone as one definition of PSA recurrence, or a nadir +2 as another definition. And one last thing to think about in this case, although the timing's not quite right, but after brachytherapy, there's the distinct possibility of something called PSA bounce. So up to 30% of patients may develop a relatively rapid rise in PSA, usually occurring 6 to 12 months after the treatment, usually asymptomatic, but then returning back to baseline. Again, the timing's maybe not quite right here, but several considerations with interpreting a PSA rise.
So thank you. Yes. So it's important to have the serum testosterone to know whether or not the rise is occurring in the context of castration or not, and to follow the PSA serially to make sure that there is a continued rise, and to rule out a PSA bounce, which can cause a transient rise in the PSA, which is most commonly seen after brachytherapy, which this patient did indeed undergo. So the PSA by December of 2020 is up to 1.98. And then by June of 21, the PSA is now 5.3. A CAT scan of the chest reveals a hilar mass, right lung mass, and an increase in the size of mediastinal lymph nodes, and a biopsy of the lymph node and hilar mass is performed and reveals metastatic prostate adenocarcinoma. So we'll first review the CT scan of the chest, and I'll ask Dr. Fromm to assist.
Here we have a single image from a contrast enhanced chest CT, single slice to the level of the pulmonary arteries. And here we see several enlarged right hilar lymph nodes and enlarged subcarinal lymph node. I think if we had an old CT scan showing that, these lymph nodes were not previously enlarged, and the development of these enlarged lymph nodes happened concurrent with the rise in PSA, I think it'd be pretty suspicious that these were sites of recurrent disease. But if we didn't have a prior study, and if there wasn't that sort of nice correlation of change in size with the rise in PSA, I think you certainly would have to consider other possibilities here. And I think, was the right thing, obviously, to go ahead and biopsy these lesions. Hilar lymph nodes are an unusual location for prostate cancer to spread. Usually we see it kind of in the middle posterior mediastinum, along the aorta, along the esophagus. Other things, lymphoma, if we do in fact have a primary lung mass, as was kind of mentioned in the description, lung cancer as well would be in the differential. Kind of an unusual pattern for recurrent prostate cancer, but I think the fact that the PSA was rising at the time, increases your pretest probability that you're dealing with a site of recurrent disease here.
In this case, with a PSA of almost 6, we did indeed see metastatic disease. But let's say the PSA were lower, or the conventional imaging was unrevealing of metastatic disease. Are there other imaging modalities that you could recommend to try to identify sites of recurrence? And I'll ask Dr. Fromm again.
Yeah, certainly we have several options in the nuclear medicine realm. Until recently, the main players were choline and F18 PET CTs, which were sort of approved for patients with biochemical recurrence of prostate cancer. In a different case in this session, we talked about the new approval of the F18 labeled PSMA targeting agent, which is approved for initial staging of high-risk disease as well as biochemical recurrence. So it sort of covers the same indications that F18 and choline covered, and then sort of expands the utilization to the initial staging setting as well. So certainly, if conventional imaging were unrevealing, or even if it were revealing, but you wanted perhaps a more complete picture of the total burden of disease for treatment planning, you could go on. And my preference would certainly be, if possible, to get a PET with the PSMA agent, just because that's been shown to be so much better than choline and FACBC.
Thank you. So we have metastatic prostate cancer in the chest. I will just before moving on to systemic therapy and Dr. Slovin, I'll ask our surgical oncologist, Dr. Abel, is there any role for surgical management of his metastatic disease?
Yeah, thank you. I don't really think that there's any role for surgical management of this prostate cancer.
Thank you. We now have a patient with recurrent metastatic prostate cancer. And I'll turn to Dr. Slovin, our medical oncologist, for comment about systemic therapy and whether or not and how you would characterize this patient as either oligometastatic or polymetastatic.
Thank you, Dr. Reddick. I was just thinking about what Dr. Fromm was saying, and I think we could probably throw a fluciclovine PET scan into the mix as well. Sometimes that's been helpful, and it's been very difficult getting PSMA PET scans, unfortunately, due to insurance constraints these days. This gentleman has a bad tumor, pure and simple. What concerns me is this large mass. Or do we see this frequently? Well, we're starting to see it more and more. This is a cancer that is presenting in a very atypical way. We do sometimes see thoracic or mediastinal nodes, but to see a big mass in the middle of the chest that looks like small cell lung cancer is rather disconcerting. Based on the biopsy, the first thing that I would do, of course, would be genomic profiling. I'm very concerned that this is going to be some sort of very unusual tumor that may or may not be, BRCA or another one that might be easily dealt with a PARP inhibitor. More importantly, though, is what has not been done, I think, is look for other markers within the immunohistology. So one of the concerns, of course, would be whether or not this is CEA or chromogranin positive, because I always want to rule out a neuroendocrine tumor. We do see prostate cancer that even though it's NKX 3.1, unless you look for something and do special stains, you're just not going to know that it's there. So clearly, I think we are probably dealing with, at the moment, more disease than is being apparent to us on current imaging, which is why I might want to do an FDG PET scan right now to see what else is ongoing. I don't really think this is oligometastatic, Dr. Reddick, at this point. I call it experience, call it a gut feeling, but I do think that either way, systemic therapy is going to be needed. And again, based on the growth rate of that mediastinal mass, I might opt for him going on to systemic therapy with docetaxel rather than going on to treatment with an androgen receptor signaling inhibitor. But I'd be interested in hearing your thoughts as well.
Yeah, so thank you for that very comprehensive answer. So I agree that I would not manage this patient as a low tumor burden oligometastatic patient. We could probably count the number of visible lesions on the scan, and maybe it technically qualifies for oligometastatic, but this is behaving aggressively. And if we did more advanced imaging, we would very likely find more disease. So I do think that and agree that systemic therapy is appropriate, and typically this would include androgen deprivation therapy as the backbone of therapy plus a second agent. This patient has an aggressive biology, so chemotherapy with docetaxel is very appropriate. Other options could include one of the androgen receptor signaling inhibitors, but I do think that many of us would consider chemotherapy for this patient. I should also point out, and ask Dr. Slovin to comment as well, about recent data that have been reported, not published, but reported now twice, about the addition of abiraterone to docetaxel for patients with metastatic castration-sensitive prostate cancer. And in high risk or high tumor burden patients, there's really a marked benefit in this particular study called PEACE-1, where the radiographic progression-free survival was extended by about 2.5 years over and above the usage of docetaxel without abiraterone, and overall survival in that high tumor burden population was improved by 1.5 years. So really pretty remarkable benefits. I was wondering if Dr. Slovin has any comments or thoughts.
This was just presented by Dr. Fizazi at the ESMO conference, and everybody appears to be embracing it. The question that ends up at the end of the day is whether or not patients can tolerate it. Now, from what I understood, there was improved quality of life. There was no major issues, but a lot of our patients have difficulty tolerating abiraterone, for example, increasing fatigue, or just a variety of different issues, hypertension, for example. And I do believe that the combination is not going to be perfect for every person. And therefore, perhaps in a case like this, when you are really dealing with the proverbial aggressive tumor, it may be a very reasonable sort of multimodality type of treatment, 2 agents, 2 different classes at the same time. What I would ask, and what I'm actually more concerned about before I ask the question, is that if we do not get a complete response or regression, how we might consolidate this. So I would ask Dr. Fromm what his thoughts would be about giving a spritz of radiation perhaps to that mass if it doesn't shrink, or even the nodes, to maintain the durability of response, even if it's suboptimal.
I think we'll ask Dr. Patel, our radiation.
Oh, I'm sorry. Excuse me. I'm sorry.
Yeah.
Sorry.
Yeah,
You
no,
probably don't want to hear what I would have to say about that.
That's fine. Anybody.
no, that's a great question. You know, I think the point, Dr. Slova, that you made about atypical histology is really important. You know, given this very atypical sort of visceral only metastasis, it certainly raises the question of neuroendocrine or small cell, something like this. One question that maybe Dr. Fromm can take after me is when do we consider a different type of a PET agent like FDG, or I don't know if dotate's ever used, but that's an interesting question. Certainly, if it was a small cell variant, I would feel much more strongly about consolidating with external beam to the chest, particularly in light of the fact that this patient is having symptoms, you know, that precipitated all of this. So I think we're going to get the best, at least initial response if we really do have a small cell or neuroendocrine differentiation. For standard sort of ductal adenocarcinoma of the prostate, you know, I think it's questionable how much response we get then from a standard sort of lower dose consolidation type of a schedule that we would typically use here.
Yeah, thank you for that. And I think we'll ask Dr. Fromm if I know Dr. Slovan mentioned an FDG PET, which is very reasonable, but would you recommend a dotatate scan? Let's say the patient did have evidence of neuroendocrine carcinoma in the biopsy. Is a dotatate scan useful in these high-grade neuroendocrine carcinomas, or is it more useful for the typical neuroendocrine tumor, let's say WHO grades 1 and 2, the lower grade type of neuroendocrine tumors?
Yeah, certainly. So yeah, dotatate PET CTs are just sort of looking for evidence of somatostatin receptor expression and tumors with neuroendocrine differentiation. They can be a good way of delineating tumor burden. Certainly, as those neuroendocrine variety tumors become more aggressive and dedifferentiated, they tend to lose their somatostatin receptor expression. We see that with neuroendocrine tumors of pancreatic or enteric origin, certainly, and that would be kind of the point in time, just sort of depending on what the histology shows. We might want to switch over to using FDG instead of dotatate, and if you're dealing with a neuroendocrine carcinoma or a carcinoma with some neuroendocrine differentiation. Certainly in the setting of prostate cancer, FDG is not one of the more commonly utilized PET tracers, but we find it can be helpful when you have that really sort of advanced castrate-resistant disease. That's the setting in which FDG PET CT can actually be one of the better ways to get a sense of the total disease burden. So yeah, I think in this case, I mean, certainly would want to get a sense of what the biopsy shows, since that was done, to see kind of what the degree of differentiation is, and neuroendocrine markers and things like that to guide the selection of an imaging agent. I did want to make one point of clarification in my first response about PET agents that can be used in the setting. I use the term FACVC, which is actually synonymous with fluciclovine, which was subsequently mentioned by Dr. Sullivan. So I just wanted to clarify that when I mentioned FACVC, I'm talking about fluciclovine, or trade name there would be Axumin. So they're all synonymous, the terminology. Just
thanks, Dr. Fromm. Yeah, so Axumin, fluciclovine, FACVC are all synonymous and can be very useful in the biochemically recurrent setting. So if we don't have any other comments, and I'll pause for a second, I can summarize the case and recommendations. So this patient has recurrent metastatic prostate cancer, we recommend that the tissue be re-examined for evidence of neuroendocrine carcinoma and potentially neuroendocrine differentiation with the use of immunohistochemistry, such as neuron-specific enolase, chromogranin, or synaptophysin staining, as well as sending the specimen for next-generation sequencing to identify a potential actionable mutation. The patient should also be referred to a genetic counselor for germline sequencing to try to identify a hereditary cancer syndrome. In terms of treatment, we recommend a combination of androgen deprivation therapy with 6 cycles of docetaxel. We would strongly consider the addition of abiraterone and prednisone after the completion of the chemotherapy, with being mindful of the potential toxicity of that treatment.
If I could just add one extra point, it would not be unreasonable to consider a combination of carboplatin and dosi. If we really think this is a very aggressive cancer, it might be prudent to consider that aspect.
Yeah, I think that's an excellent point. A platinum like carboplatin could be added to the docetaxel, especially if the review of the pathology shows evidence of neuroendocrine carcinoma. So I thank the panel for that excellent discussion.